Welcome to the first breakout session of ATMRD. My name is Kelly Papesh. I'm a nurse practitioner and the clinical director at PMD Alliance, also executive director of the Association of Movement Disorder Advanced Practice Providers. And we're really excited to begin today's breakout session with the topic, Lips Sealed, What Your Patients Aren't Telling You. This topic has become to us more than just content that we want to discuss at ATMRD. We found that in going through what we want to discuss, we did a live virtual webinar and a survey to patients and care partners of people living with Parkinson's, and we found out what they aren't disclosing, what they're withholding from their healthcare providers, and it helped gain insights for us into what we can do better collectively. I think it's really eye-opening what we found out, and it's such an important topic because we can't treat and we can't manage what we don't know. And so we're here today to talk about what we can do better as teams together, and as healthcare providers, as advocates for ourselves or our loved ones. And Anissa was one of our spearhead for getting all of this together. I'm going to have each panelist introduce themselves, but Anissa really led the drive today with all of our the webinar, the survey, and we have a poster, so you'll have to check that out as well. We're excited to talk about this today, and with that, I'm going to let the panelists introduce themselves.
All right, hi. As Kelly said, I'm Anissa Mitchell, and I am the Chief Program Officer at PMD Alliance, and I'm also a clinical social worker, and I have worked directly with patients and families for 14 years, specifically in movement disorders, mostly in Parkinson's, but not just. And I have had the experience of learning things that people weren't disclosing over time in my work with patients and families, doing one-on-one sessions with them, or even just finding out things in support groups or other, side conversations. And, so when we talked about this particular session, I felt like it was a really good conversation because I've obviously, working with healthcare providers, hear that side of the story too. And so it was really curious to me of how do we take the two sides and connect them together so that the needs of the person are being addressed appropriately. Because if you don't know what's going on, you can't obviously treat it. And really felt like this is a great opportunity and a great conversation for this particular place and time. And I love that we have the voices of many people that's involved, advanced practice providers, physician, and we have the patient voice and the care partner adult child voice, because I have found, obviously, and I'm sure you have as well, many instances where you learn about things from the care partner or the adult child. And that can create some very interesting dynamics. And so it isn't just the symptoms that, are important to know. It's all of the psychosocial and family dynamics that play into it, because it does have an impact on compliance and how their quality of life is. And so I really feel like this is a great opportunity to kind of unpack this a bit.
Hi, my name's Pam Zelman. I'm a nurse practitioner. I've worked in movement disorders since 2006 at the University of Florida. I primarily work with patients that have deep brain stimulators. But I was intrigued. Actually, I think my response when I was invited to be on this faculty was, I would really like to observe that talk. Because I think that this is something that's really important in terms of both for good patient outcomes and then also good communication between the provider and the patient. A lot of these subjects are embarrassing to patients, or they're afraid that some of their independence or power is going to be taken away from them if they give us certain information. So we have to be really careful in terms of asking those questions and then just trying to build a rapport so that we're able to effectively help them. Yeah.
So my name is Christina Ospina. I'm a movement disorder neurologist in private practice in Phoenix, Arizona. And I agree, like Pam said, You know, we're very good at treating the motor symptoms of PD and sort of zoning in on that tremor, that dyskinesia, and sort of dialing it out, especially with DBS. But it's really the non-motor symptoms that affect the caregiver and the family as a whole. And we need to look at the patient as a whole being and not only treat the tremor, but that orthostasis, those urinary urgency, those hallucinations. And we need to partner with the patient, because if they see us as somebody who's going to take away their driver's license or stick them into a long-term care psychiatric facility, they're less likely to open up and tell us about the cat that's been living with them that they don't actually have.
Yeah. Hi, my name is DePorter, and I'm the lucky panelist that has Parkinson's. And I'm here as a patient voice for others who don't always get a chance to say what we're thinking and feeling. And I'm very grateful for events like this and that you include the patients, because we want to tell you how we're feeling and how you can help us. And this is a great opportunity for us to do so. Thank you.
My name is Adam DePorter. In this situation, I'm the care partner for my mother here, and I've been involved in some of her diagnosing from the beginning. I also have the perspective, I'm also a physician assistant, and I actually work in rehab medicine currently and was also a hospitalist. So there's a little bit of a dynamic there that we'll get into at some point as we kind of progress.
Yeah, thank you. Wonderful group. I think we're going to get many perspectives on how to best go about, getting the information we need so we can better care for our patients. We did a survey, as I mentioned, and that data has helped kind of guide what we're going to talk about today. And so I'm going to let Anissa go through some of the data on that survey with us. Here's some disclosures.
Okay, so it was a small survey. We had 79 respondents. They were both people with Parkinson's and care partners. And it was mostly open-ended questions. We went through the data and we sort of categorized it, coded it, and from there you'll get to see some of the things that we surfaced. So of the 79 people that responded, 82% of them admitted that there were symptoms or issues they were not disclosing to their healthcare provider. Interestingly enough, when we asked them if we believed that sharing these issues with their healthcare provider would be a benefit, they said, well, maybe and yes. So around 82% said, yeah, positively, it probably would. So, why? Why is it that they have these things that they definitely know that they're not disclosing, yet feel that there's a benefit? How do we bridge that gap? You can go to the next slide.
Yep.
So then we wanted to dive into exactly what things they were not disclosing. And you can see from this graph that two of them are pretty closely tied. Those autonomic nervous systems, specifically the GI, urinary, and sexual dysfunction issues, were really frequently reported. Obviously, the little graph on the side, thank you, with the sexual dysfunction was more common. That was usually reported as erectile dysfunction. This was not hypersexuality. These were more specific to the autonomic nervous system, and then followed by urinary issues, incontinence, and then GI issues. And then the mood disorders, you can see the depression was the most common, followed by anxiety and fear-based issues, and then some, what I would call maybe grief experience, a lot of anger, grieving, frustration, despair type of mood issues. Then we had people identifying cognition as a significant issue that they were not disclosing. We'll kind of give you some of the verbatim responses, some of the reasons behind that. I'm sure you probably can understand a lot of that is related to fear of what the future might hold. And as I think Pam and Dr. Ospina mentioned, just that fear of losing control and self-agency. And then self-perception was pretty significant, as well as other psychosocial issues. So a lot of people just feeling like they've lost their sense of self and who they are, and just feeling that whole existential pain. And then a lot of issues in terms of family dynamics, changing roles and role reversal and family shifting, of just being able to relate to each other as they were maybe husband and wife, partner, adult child, and parent. That can be very, troublesome at times. And then we did have some people talking about neglect, lack of support from their care partners or family members, being very alone. And so some of those actually raised some concerns that, would really be benefit from deeper dives into what's going on. One that actually raised some concerns about some potential abuse. And obviously these were anonymous, so that kind of left us unable to do much, but that just kind of shows you that that is a potential issue that people aren't necessarily giving you up front, that sometimes there's some scratching away at the surface to find out maybe little comments that they make, and kind of deep dive into some of those things. If they come in and the care partner's never with them and they make excuses, well, you might expect that for a little bit of time, but then you really want them to have that person beside them. Why is that? And what can you find out from deeper conversations?
Yeah. I mean, thank you for sharing that, but wow, I mean, it's 82% aren't disclosing something. That's pretty significant, and we have work to do. It seems like there's a large gap. When we look at the biggest reasons they aren't sharing it, it comes down to ideas around communication. And so I want to just talk about, what is it? What is the HCP patient care partner communication like right now in healthcare? What's our experiences? And what does it look like? Why are we seeing some of this? So how do we, what is the importance of open communication in healthcare? And we know this goes both ways. It's the provider, it's also the patient and the care partner, but how can we do better to effectively advocate? Pam, yeah.
Well, I think the obvious answer is yes, it's very important to have open communication, both between the healthcare provider and the patient with Parkinson's. I think first you have to build that rapport with that person. You can't expect that to happen on the very first visit. So it's a matter of seeing that person consistently over time, building a rapport, and then trying to ask the right questions, especially when maybe they're at a point in their disease that certain things are going to crop up. Some of these topics are uncomfortable, so it's bridging that, in terms of, sometimes you don't know what you don't know, right? And some of these patients, they may struggle with urinary incontinence or constipation, and they feel like, well, that's not related to Parkinson's, so it's educating as well. You have to really educate the person in terms of symptoms that can crop up and that there is things that we can do about it. And then some of these topics are really difficult. So if you know that someone's on high dose of medication or they're on a dopamine agonist, dopamine agonists can really drive impulse control disorders, and that can be very disruptive, embarrassing, causing problems with gambling or hypersexuality, and then those issues are embarrassing. So it's just, bringing up those topics, and then if you have established a rapport with that person, then they're more likely to feel comfortable to talk to you about those issues.
Mm-hmm. I think in our clinic, we always have our set questions that we ask, everything from falls to hallucinations, and that happens from day one. And so that when they do crop up 5 or 6 years later with hallucinations, they're like, oh, it's not out of the blue. Somebody's already been asking me about it. And so I feel more comfortable telling them about whatever little people or little cats have been running around. But I'm kind of curious to know from Lori, because some patients might say, well, gosh, I don't want to be asked that from day one. Maybe it makes me scared or uncomfortable thinking, well, is this going to happen to me? Not everybody gets hallucinations, but if they start asking you about hallucinations or bladder issues, is that going to make you feel comfortable or less uncomfortable, or thinking am I going to get all of these things?
It's a little scary, I'll be
honest.
Scary. Yeah. I try not to project, but I'm a fan of Brian Grant, and he calls it future tripping. And so you try not to trip too far into your future, because you don't know what it's going to be. We're all different. Our journeys are all different. But I think one of the big things for me personally is it's a mental hurdle. The more I tell my doctor, the more I feel like I'm letting him down and letting my family down, and it's winning. and that makes me mad. I don't want it to win, I want to win. But there's also, you have to keep your like reality like real. I mean, I know that it's there, it's not going away, but I also know that there are a lot more resources out there that people can use now than when I was diagnosed. There's so much more available and ways to learn, and I think one way to get people to share is give the patient an opportunity to be alone with a physician. I mean, I love my husband to death, and he comes with me when he can. I love Adam to death, but there's certain things I'm not going to talk about in front of them, whether the doctor's there or not. So if I had 2 minutes alone, or I mean, with a nurse or whatever, that I can just be unapologetically me, that would probably open up a lot more than I would tell if they're in there with me the whole time.
And I think to that point, and a lot of that speaks to, sure, you'd be comfortable discussing your tremors or dyskinesia in front of me, but some of these non-motor symptoms that are obviously the ones that are not reported speaks to that. That might not be something you want to disclose in front of a care partner. That could really be detrimental to care long term. So I think that kind of correlates and meshes together pretty well.
Yeah. No, I agree with you. Oh, go ahead.
So, but when would you want to be asked about hallucinations or impulse control disorder? Only after you get started on a dopamine agonist, or?
Well, one thing my doctor did that was kind of cool, and I don't know if this is cool, everybody's thing, but she would give me, when I was on a medication, she would say, like, I will tell you what to look for. And she would tell me what to look for from day one. She's like, don't read the symptoms, don't read the side effects, just and then when I would go in there, she would say, have you been hallucinating? That didn't bother me, because it is all part of it, but it's important to say, you may not have this.
Right.
But it's important to know that you might. Because side effects are important to know, but you can't obsess over them.
Right.
I could see that being a bit of a double-edged sword, because at the same, you want to be upfront and open, but at the same point, I remember with your situation, it was information overload, even at what we weren't told, So I think to a degree, I think easing into that conversation probably makes sense, but probably right off the bat, I don't know how well that would have went.
Yeah, too much information can sent me personally, sent me down the rabbit hole. Like, he would come home and be like, you were on the internet.
You were on.
Yeah.
And I'm like, yes, I was Dr. Googling, I'm sorry. So I think too much information can send you down a road you don't want to go down.
And so then you felt that if you disclose more things, like, oh, my bladder's not working the way I want it to, you felt like, oh, the disease is winning and I'm sort of giving in, and so I'm not going to say anything about the bladder? Or?
And maybe my bladder's fine, but because you told me my bladder might not be fine, I'm thinking it's not fine.
Oh, okay.
So, Lori, one of the first things that Pam mentioned was you have to, if you want someone to open up, you have to build that rapport. Do you have experience with this? What can providers do to help build that rapport? And what has your experience been with that as far as time with your provider, or even, just the importance of different topics, and like, how do you build that rapport to be able to trust them to give what you need?
I've been very fortunate. I've had 2 MDSs, and one, I've been with them both the whole time, for 10 years. And they both took the time to know me, but one more in particular than the other. But I was kind of joking that, our appointments are always late. We expect that you guys are running late because there's not enough of you and there's more of us. So take 30 extra seconds to ask me how my breakfast was. And it kind of levels the playing field, and I don't see you as just that doctor up here and I'm that patient down here. We're kind of on a level playing field, and it makes me more comfortable to talk to you, because I know that you're eating breakfast and I'm eating breakfast and you care what my breakfast was like. That may sound stupid, but it's real. And when I took Adam to one of my first appointments, and we were late, and my doctor said, go get a cup of coffee, I'll text you when I'm ready. Okay? But when I got in with him, he took his time, and I waited my turn. I didn't feel rushed, and he was like, I can't believe how much time he spent with you, and it made him more comfortable with my care team. So he could kind of be like, okay, I'm cool, she's cool. Yeah. And I think that made a difference, and just like I said, making that little effort to know one little thing about somebody can make a big difference.
The transition from the person that's just there saying, yep, here's your Cinemet, versus, let's have a conversation about what we're going to do and what the game plan's going to look like, as opposed to, sort of that, the provider being here and the patient being here. I think that's a good point.
Yeah, I love that. I think it makes sense. We're all human. We all want to be treated equally. And so if you feel like you can relate to your care provider, or if your care provider can relate to your patients, you feel it's easier, right? You have that relationship. One question that I wanted to get into, and one discussion topic, was the impact of patient silence on diagnosis and treatment. So when that's not disclosed, or how you go about sharing that with friends and family. And when you talk to friends and family about that, does that impact like what you're sharing with your provider? Are you sharing different things with your provider than you do with your family? I know that care partners may see a difference in what they're being told versus a care partner or a care provider.
Is this me again?
I'm kind of throwing it to you and Adam first.
Okay,
and then I want to talk to the social worker here
okay.
about this, yeah.
That's fine. My big thing is what I'm feeling inside and what's going on with me is not necessarily what my care partner is seeing or what my family's seeing. Because as I may have said earlier, I'm a mom. I can't turn off that switch just because I got Parkinson's and let them see everything that's going on with me. But it's also my responsibility to communicate with them because it's not their job to help me if they don't know what's going on with me. So it gets easier, but it's hard.
Yeah. And we've admitted as a family before we struggled with that in the beginning, trying to understand, because again, you picture even, again, as someone that worked in medicine, or even that doesn't, the stereotypical Parkinson's patient, and that doesn't exactly look like what you typically see. So trying to understand, what are these symptoms that are Parkinson's that, I'm not seeing this massive tremor. I don't quite understand how much of these symptoms are really at play, and trying to figure out the dynamics in a family about how that works out. I know you've used the iceberg analogy before. That's always a good one. Where you might have a fine hand tremor, but when in reality that's only just the tip of the iceberg. When the biggest symptom that you might be dealing with is anxiety or depression or some of these non-motor symptoms that, again, for us kind of getting through the diagnosis, we're not very keen or very aware of. So that was definitely challenging. I think, and you're right, it's definitely gotten better with time, and kind of speaks to the importance of communication in general.
And I think what would have helped me as a young onset person, like everybody was like, you can't have Parkinson's. You're too young. You're a woman. But yeah, here I do. I have it. Had a DAT scan. Says I do. So it would be like I didn't have a whole lot of connection with other young onset people. I really kind of felt like I was alone until I started getting involved in other things and kind of basically as a family we said we got to take the pity party hats off. It's time to dive into this. And I did the Rock City boxing and I got involved in the community and met other people and became active in the community, and it's become a lifeline. And I think it's important when someone is newly diagnosed that they know that there's resources out there. They don't have to wait till they see their doctor in a year or 8 months or whatever it may be. There's other people out there in between that can answer questions and be reputable sources. And you're not alone. There's no reason to be alone.
Mm-hmm. Anissa, do you have anything to add with this?
So yeah, well, I was listening to you, and I appreciate that perspective because it's so important for us to hear that. So when I've met with people before, one of the things that comes to mind is that people have ways of dealing with life and coping that, was there before the diagnosis. Mm-hmm. And so you have people that are minimizers. You rather not talk about uncomfortable situations. They tend to avoid things that are uncomfortable. So, sometimes motor symptoms are quick and easy. I'm off, my tremor is back, and, those are things that are tangible, they're easy to deal with. But when you dive into some of these non-motor symptoms, then you're unpacking things, and you guys have mentioned it, and the data reflects it, this fear of losing the control, but also embarrassment was a huge thing that people identified. There was a lot of people saying that they didn't want to, and I think, Pam, you may have mentioned this also, let their healthcare provider down. They tended to either flat out deny symptoms that were occurring or they minimize them. And I don't necessarily go about it from my perspective that they don't accept Parkinson's symptoms themselves, but is it related to pre-existing coping that they had or issues within their family dynamic? Do they not discuss things with their care partner or their child because it's a mom thing, or it's because I don't feel comfortable with my family knowing these kind of things, because our culture and our family is very private and we don't disclose things. So it's sort of like, from my perspective as a social worker, I'm not just looking at, you know, what are the issues and why are they not sharing it, but what is the reason behind it? What is the family like? So it's like a whole history. You take a social history, you do a medical history, I do a social history. You know, what is the family dynamic? What were the behaviors before? What was the general practices in your life and dealing with other situations that came up that were challenging? Because those are also reflected when you're dealing with something like that. How do you feel about this? Are you angry? Are you sad? Are you just in disbelief? Because early on, I think people feel fairly well. I can say from many people I talked about, they weren't ready to talk about psychosis and, you know, long-term care planning and all those things, even though it might be good for them to do that early so they're not crisis managing later. But that's not where they were, and that's not where their headspace is. And so you sort of have to meet them where they are. And I think that's the benefit of having, you know, a whole team where you have a social worker that can kind of meet with them and do this over time, because it's not something that surfaces immediately. And if they're newly diagnosed, that's not the kind of information they need. They may need to figure out where they are in just accepting this diagnosis. What does this mean for them? Some people, and I can't remember who shared it, but it was just an article that just came out, I think out of Parkinson's Europe, that, you know, people have started to accept their diagnosis even before the diagnosis happens now, because we have more understanding of the prodromal symptoms and maybe we're getting better at the diagnosis and they've had a little bit more information to kind of help them process. But you know, really some people are ready to, and maybe even relieved to find out, you know, what it is, and others may be like in a spiral. And so you have to figure out where they are, and is that the reason why they're silent, or is there something else playing into it in their life?
We need someone like you in every clinic to help figure that out, right? Because not everybody has access to a social worker, and you were mentioning resources are so important right away.
And I think the mental health piece is a big thing that's missed.
Yeah.
Not because you're not looking for it, but because we try to hide it. And I think my son has more to say on that than I do.
Yeah, I think, and I've kind of hinted towards it, but I think that was the biggest hurdle for, I think, you as a patient, us as a family, was trying to get to that next step of, you know, really admitting how significant and impactful some of those anxiety issues were. There were times where I know she downplayed it to us and probably to her providers as well, and I think, you know, and was on probably some medication that she probably didn't need for longer than she needed, and it took a while to really get to some of that next step where there can be care that was actually beneficial towards just how things went in general. And I think, you know, it was, you know, obviously the clinician was looking for it to a degree because there was some medication there, but it certainly wasn't to the extent that it needed to be. And I think that, you know, I think you'll be the first to admit that that set you back a couple years, even in terms of how you felt and how things were. So yeah, and again, for the same thing, you know, it's not that we weren't looking at it as, you know, as care partners too, but without knowing the involvement and how significant and how real it is within Parkinson's, you know, we'd say, okay, she looks like she's doing okay, the tremors look fine today, I guess things are all right. And, you know, that's just, you know, without, you know, having that next step and taking that, the time to really get into the significance of the mental health issues, it can be detrimental to the patients, for sure.
I think that's where sort of a whole iceberg there that no one is looking at, and so that it's just not the tremor, And so the better educated the family and the patient is that anxiety is not just part of the non-motor, but it's part of maybe your off periods as well, and that we just don't want to put a Band-Aid over it and give you, an SSRI or, a benzodiazepine, that if we treat your off periods, that anxiety that's premotor is going to get better. But if we, as clinicians, don't ask the right questions, so, we've gotten better at asking questions. Before I would ask patients, how are you doing? And they would always say the same thing, I'm doing fine, I'm great. Because, as you said, like they don't want to get worse and they don't want to sort of, if I am getting worse, I'm giving into the disease. But if we ask questions like, are there things that you want to do that you're no longer able to do, then that will bring out off periods that then we can address. And then we can treat those specifically and then educate towards that, so that we're not missing, anxiety because of off, and we're not missing off periods because, and you're not sitting at home not doing anything because you're just undertreated, and you come in and say, yes, I'm good, I'm fine every day. It's probably one of the reasons why we all went into movement disorders. The patients are super nice. And so, what I tell support groups today is to go and complain at your doctor's office. Don't be super nice. Tell them, things aren't, why am I putting up with good enough? It should be better. And we have all of these new drugs that we're not using because if you just say, and the reason that clinicians are conservative is that not only are doctors conservative by nature, but in Parkinson's disease, all of your medications, they're good at treating the motor symptoms of PD, tremor, rigidity, gait, imbalance. They make non-motor symptoms worse. So I'm going to make you orthostatic, I'm going to make you hallucinate, I'm going to make you compulsive. So if you come into the office and you have a little bit of a tremor and you tell me it doesn't bother me, I'm not going to change your meds. But if you tell me, yeah, it keeps me from woodworking or quilting or sleeping, then it's worth it to me to make you a little bit orthostatic, to change your medicines and then treat that orthostasis. And so that, we have to understand why the patient is conservative and why the clinician is conservative.
Well, and going back to the mood, you're 100% correct. Sometimes you can have these off anxieties or even depressed mood in the off state. So then you want to try to adjust the medications to get the best on state with the least amount. But sometimes it's not related to the off. It's 40 to 60% of Parkinson patients can have difficulties with mood, and there's I don't know what's the right word I want to say, but there's just this stigma of taking medications to help with depression, or a stigma of taking medications to help with anxiety, and it's a big roadblock for patients. So the next thing you really have to do is educate. And I first start educating in terms about the carbidopa levodopa. And I ask my patients, why are you taking the carbidopa levodopa? Well, and they give me some, answers. And we talk about how the levodopa breaks down to dopamine because we need to replace a neurotransmitter that's deficient in the brain, which is dopamine. And they readily take that dopamine because the motor symptoms are in their face and they can see the response in general to that medication to replenish that neurotransmitter. But the neurotransmitter that's also deficient is serotonin and norepinephrine. And then I point out to them, but you're not taking any medication to replace that deficient neurotransmitter, serotonin and norepinephrine. And this is why we're struggling with some mood issues. And when you struggle with those mood issues, that's going to adversely affect the outcome of your Parkinson treatment. And I have been able to turn around some patients to be more open to the idea of taking these antidepressants or anti-anxiety medications because I go through an education approach of how this is affecting them on a chemical level and then just also in general in terms of their Parkinson's.
Yeah, and Parkinson's is very much sort of the poster child for the mind-body connection. So everything they're thinking, feeling gets reflected in the Parkinson's disease. And that's why it's not only do we want to know what you had for breakfast, but what's your dog's name? If your dog died, your PD is going to go in the toilet, and I need to know why your PD is in the toilet. Is it because your dog died, or your PD is progressing? And so that if you know who the dog's name is and how old they are, and were they in the vet or not, then I can figure out, is the PD being affected by the dog's health or something else?
And then if you find out they have 8 or 10 cats, you have to look at the dopamine agonist.
Right.
And patients are willing to try different things. I'm going to kind of out us here. My doctor at Hopkins he's very big into music and the brain. And he said, have you guys ever tried dancing? And I'm like, not really. We dance, but he's like, the Argentine tango and ballroom dancing is very good. So I went home and said, we got to take dance lessons, honey. And we ended up taking dance lessons pretty regularly. It's kind of fallen off now, but it added a whole new element to our relationship, but it was also became part of my care plan, really. Yeah. And when you tell your patients to exercise, right, we all know exercise is good. Everybody knows it, but tell them why it's important. Like, don't just say just exercise. Like it's all part of that
education.
Dopamine, make you feel better, and it all works together. And I think understanding why you should do things is important, not just here's a pill and go exercise. And then also treating it as a family disease. It was not just my disease, it was my whole family's. And I think I had I saw a counselor right from the beginning, but my family didn't. And I think it would have benefited us as a family to have gone together, but then again, still have the stigma of mental health, and tell a 16-year-old he's gonna go to, a psychologist with his family, I probably would, well, no, I'm not. Right, Ryan? But it's important. I think that would have been important. And 10 years into my diagnosis, I learned things about my family that they struggled with that I had no idea was going on. And maybe that would have been avoided had we had some therapy as a family.
And just for clarity, it was my father that did the Argentine tango, not me.
Yes.
But no, I think to your point, we've talked about that too, is that, it all circles back to not just communication between the care person and the patient and the provider, but also understanding, as providers, that there is that family dynamic as well, that it could be playing a huge role in the back, in behind the scenes that, we're not, as a provider, in my case, I'm not always privy to that either. So I think that's an important thing to at least be aware that could be playing a role that you might not see.
Well, I think, like you said, the why is super important. So anytime we're changing medicine, we're adding medicine, there is a why, and your clinician should be able to explain the why. Why am I switching you from a 3 times a day dopamine agonist to a once a day, or a once a day COMT inhibitor, or a longer acting form of levodopa? There should always be a why so that you buy into the therapy and say, okay, this is worth it for me to make this change or add a new pill. Because if you understand the why, you understand the why, the gastroparesis, the sleep problems, that sort of thing. So I think, that's where it's hard is, are you in a center or a place that is able to provide that education? Like, do they allow the provider to spend the time with you in the clinic to take care of you? Or is it just, pill mill, like here's your script for Cinemed and here's one more pill?
And I know we personally struggled with that early in your diagnosis. As you mentioned, you've had good physicians for the majority of it, but in the very beginning, I was still in PA school, so I knew enough to be dangerous, but not anything else. And there was a lot of times where, in the beginning, this medication came up, and you'd be wondering, why did they change that? And sometimes you didn't really have a good answer. Why are you on this medication? And we didn't have one, and that caused, like I said, I think, a little bit of time to lapse before we got to where I think we needed to be, because there wasn't really early that good communication as to why, or, until we kind of move past that.
I think sometimes providers, we do provide that information, but then there's so much information being given at that visit. It's also hard sometimes to remember the instructions or remember everything that was discussed. So one thing I try to do, in my healthcare system, we use Epic, Cerner, some people, but I have a lot of just quick, smart phrases of frequent educational things that I give folks. And so I try to make sure before they leave, if I change their medication, I write down why I'm changing it, what we're trying to help with, what to watch out with, and I type in some quick patient instructions with additional information. And sometimes that's good. And sometimes it's not, because sometimes it's just too much information, you know. But it's very helpful for after the visit, because especially sometimes spouses will message me and they'll say, you know, we can't agree on if you said X or Y, and then I have to. So I don't get that message back as often now anymore, because I try to be really good about giving them as much information as I can written about the visit and the changes we make. And also for, you know, if they come to the visit without their care partner or without a family member, they have the information written there, and that also helps to communicate with people who couldn't make it to the visit for whatever reason that is.
Well, and that's why, like, we want somebody always there with the patient, so there's another set of eyes and ears to listen to the visit. And then I think to get around the fact of, so many times patients will hand me, or the MA will be like, oh, this letter was sent to you to read before the patient visit.
Yeah.
So if you don't want to discuss that in front of your, you know, partner, I already have the information of like what was going on as far as hypersexuality or, you know, impulse control disorder or shopping on Amazon, and it doesn't have to be disclosed at the visit in front of the patient. But then there's still 2 or 3 people in the visit listening to the visit, writing down things, and so that when you go home, there's less, was it 2 capsules of Rytari or 3 at a time? I don't remember.
I love that you reiterate to patients and have them say back to you, Pam, like, what is it that you're taking X, Y, and Z for? Because it helps with the education component. I wanted to ask quickly to you, Lori, the impact that you would feel if your care partners are writing to providers, like behind your back or ahead of the appointment. Is that something that you would be okay with? Is it something
No.
that is, you know, how does that feel? Because we get that a lot as providers.
No, I would not. But I think you guys have a challenge as providers, because your demographic is changing. You don't have just the older generation that needs to have somebody be their advocate and needs to communicate for them. I'm quite capable of talking for myself and listening for myself. I do bring somebody with me for a second set of eyes and ears, but your gap is growing. There's more younger people coming to you and being diagnosed, and that demographic is shifting a bit. But because I will tell you, what you may see in a person or what their care partner may see may not be what I'm feeling. Like, you know, I know when I get up in the morning, I shuffle. And there's times when my medicine's wearing off and I look like I have a walker, but there's really no walker there, and I'm kind of just shuffling along, and my rigidity's bad, and you know, it's horrible. But I mean, I know I'm going to take my medicine. I know it's going to go away. But you know, my care partner may see something totally different. So, but I would want him or them to talk to me first before going behind my back. I would feel like it would be going behind my back. I wouldn't mind it if you said, "Hey, I'm going to touch base with your care partner or with your doctor," but I just feel like that kind of that hurts that trust thing.
And so, but what would you do in like driving? So the patient never feels like their driving is impaired, that their reflexes are impaired, but the family does. And so the family brings it up. So how would you, or impulse control, like if they're doing lots of shopping, and for the patient it seems completely normal. I wanted 5 sweaters in 5 different colors. Of course I did. Why wouldn't I want that?
Right.
But we know that that's, you know, you're on 4.5 milligrams of Mirapex, it's all due to the Mirapex.
Right. Well, I am on 4.5.
Right.
And I do shop on Amazon,
Right.
so we could be in big trouble.
But it all depends, like, you know, are you going to get into credit card trouble or no, you know?
But I think still, sit me down first. I'm
Yeah.
at an age where you can sit down, you know, but when I'm, you know, knock on wood, 80 years old, and you guys are dealing with me, it might not be the same. You might have to call my doctor and say, look, she's still shopping like she was, you know, but, or, you know, she's still trying to drive. But I think you have to look at each individual patient. You can't look at it as the patient who's not driving well or the patient who's on an agonist or whatever. It has to be the 45-year-old patient that's on an agonist. And I mean, I have the ability to be rational.
Right.
So I think that kind of, I mean, if it's a safety issue, absolutely. But I think that the demographic is changing. I mean, there's a lot more women, there's a lot more young women, and I don't know what that is or why that is, but it's a different animal. It's a different disease almost, and you have to kind of treat it that way.
Adam, what does that feel like from your perspective, talking to your mom about things
So,
she needs to be doing better?
Yeah, I think it's complicated for a lot of different reasons, because it also speaks to the delicate balance between having a second set of ears at the appointment, but also, like you mentioned earlier, wanting to have the ability to have a conversation, and say things on your own. And then it also is, again, the very delicate balance between, is this something that could break trust by me or my father going, saying, hey, this is a symptom we've noticed that she doesn't see. And maybe it's as simple as, I'd be more apt to say, can you discuss it with her and see if that's a way that we can, manage it directly, as opposed to, you kind of going behind your back, so to speak. I think that puts, it certainly is a challenge for a caregiver, but I also think that it at times would be appropriate, but I could definitely see how you want to try to directly address it with the patient first, knowing that there may need to be more on individual cases, but I think that's a difficult challenge, to say the least.
It's part of that family strain that occurs, because there are instances where you have the person, with Parkinson's or movement disorder that, is capable of making their decisions. They're, very able to say what they do and do not want, but they have one perspective. Their family, their care partners may be seeing something else. They're both valid concerns. You don't want to take away from the patient's sense of agency, but also the strain that it can cause in a family if they don't have the capacity to talk through that. I've seen so many families get into major upheavals and have, relational issues because of these things. And it's usually related to things like you mentioned, driving, or the shopping thing that's come up quite a bit, or gambling. Like, you may not realize that you've actually bought scratch tickets every single day this week. Like, this is eating up money that we don't have, or you seem to be very fixated on certain things, and you really aren't sleeping or eating well. Mm-hmm. And it's very concerning to me that, maybe there's an awareness, maybe not. And it's important to have that open conversation. And I think that's where, being able to sit down with the family and seeing, first of all, like, if I were working with you, Lori, I'd be like, tell me how you're really doing, not just, the surfacey things, but like, how are you really doing? And how are things at home and with your family, with your children? Are you guys good? Are you getting along well? Or is there anything that's stressing you out? Or you guys been arguing about anything recently? Because sometimes it may not initially look like it's related to issues in the disease or symptoms or whatever, but it could be. Again, it has a lot to do with how your family interacted before this came to be a part of your lives. But we've had a lot of families kind of have the adult children, and then the parents kind of get into an argument, and we've had to kind of talk them through it, because the kids' best intention was to be helpful to their parents, but then they sort of overstepped their boundaries. Mm-hmm. And so trying to find out even what's a healthy boundary for that family is really important too.
Absolutely, I would think that would be hard, especially with geography and things. You're not like, you're gonna blow in for a half hour and be like, oh, we're gonna fix everything. Like, it doesn't really work that way. But we've definitely had communication issues. I think we learned that. And I always tell, like, if I ever meet a newly diagnosed person, like, talk to your kids. They're smarter than you think, they're more resilient than you think, and they're gonna find out anyway. And it's better to come from you than Dr. Google. Because
it's true.
It just isn't, it's just not a good thing. And
Anissa, we have, many centers do have access to a social worker, but some don't. Do you have any advice on how to navigate that as a healthcare provider seeing a patient when they're maybe challenging family dynamics?
Yeah, it's unfortunate that every place can't have a social worker just to be supportive to your team. We have in our community, we've recommended where I live, if there's not a social worker that's working with them, to see if there's a hospital social worker that might be able to work with them, or a home care social worker that's out in the community. Sometimes you can find social workers that might be in private practice that also are able to, or some social workers work for like Aging Life Care Association. They might be care managers, and so they're already in the home and they're working with the families and helping them kind of plan and deal with issues as they come up with aging and aging in place and all of that. So they often are able to kind of help if there's not someone in that clinic.
Yeah,
I'm
go
raising
ahead.
my hand.
Yes, please.
I'm going to turn the tables a minute. I'm going to ask you something. How many of you feel like you don't know when there's a family dynamic issue? Like if we don't tell you, if I don't come in and say, hey, I have 3 sons and a husband and it's getting a little dicey or whatever, like how it's important for you to know that dynamic, and how do you try to get that out of us if we don't tell you?
Yes, you would have to tell us, because we're not going to know that there's 3 kids and one
So you're
kid
trusting
is doing,
me to tell you.
that one kid is doing all of the work. So unless, that was one of the good things about COVID, is that when we went to telemedicine, then we could have like the kids that lived on the East Coast were all in on the phone call, and so you could have all 3 children on there, and everybody was on the same page. And then now post-COVID, now the kid that lives in Phoenix is the one who's doing all of the care.
Right.
And then the other 2 kids are like, well, I live in Pennsylvania, so not my problem. What am I supposed to do? And so, yes, if we don't know that's going on, we don't know.
I think switching gears for me as a clinician, where I work at a rehab hospital, I'm somewhat tuned into the social stuff just because of discharge disposition and things. But this whole situation for me is, if nothing else, brought out this perspective that we have to be very aware that even if I can't get to it in my short time there, we have to be aware that there's probably some family dynamic things going on in the background, even if it's, not that I'm going to get to it 100% in that visit or in that particular situation, but sometimes that social history isn't necessarily the focal point, and a lot of times it doesn't necessarily have to be, but at the very least you need to be aware that that's happening in the background. And like I said, because I've learned from this perspective to know that, had I seen her as a patient in rehab, I never would have thought any of this other stuff from a social perspective was ever at play. So
I wanted to circle back in terms of that anonymous reporting aspect. And it doesn't happen very often, but it does happen from time to time. And I usually do try to, the person who's anonymously reporting to me, try to have a discussion with them separately, in that we do need to openly talk about it. And because we can't treat or, address that symptom or problem openly, right? I mean, sometimes it's helpful because it'll cue me to ask certain questions, but we really have to be part of it together. And it's not always necessarily an issue like with the dopamine agonist or other things. I had, recently I had a patient that I could see, she was continuing to decline. She had had Parkinson's for 30 years, and I knew we were kind of getting near the end. And I had talked about palliative care and hospice care, just kind of this isn't something we have to think about right now, but just to have it kind of on the horizon. And then the son called and messaged me and said that he wanted me to go ahead and initiate hospice because he thought that we were there, but he didn't want me to tell the patient, his mother. Well, his patient, the mother, was a retired nurse. I think she was going to figure out hospice was there. And I said, we really need to, this is something, I'll bring you in. I brought him in front of your mom. And the reason he didn't want me to talk to her about hospice is he didn't want her to cry. And what I told him is, it's okay to cry, and it's okay to be sad. But we have to openly talk about this so that we can get the resources and get what you need into the home to help your mom. And your mom, being a nurse, she's going to know.
Right.
So,
I think that's such a key point, because we tend to want to avoid those uncomfortable conversations. And I think it's okay for us to just bring them out, put them on the table, and normalize them. And I think that was kind of in some of the data that we covered was like the reasons why, and I think I mentioned this, I don't know if this is on the next slide or not, but oh, that what, that's the what, the why.
Oh, the previous one?
Yeah. No, the one coming
sorry.
after. I think it's coming, yes.
Yeah.
So the why they're not sharing, you know, is because they are embarrassed on many different levels. They're embarrassed of the body changing. They're embarrassed of, you know, maybe that's just, those aren't the kind of things that we talk about. You know, we don't like to talk about uncomfortable situations. My mom had Parkinson's, and she was the ostrich. She would always bury her head in the sand. She didn't like to talk about anything uncomfortable ever. And so anytime there was something that came up, like she wouldn't disclose that to her doctor. And, you know, she would rather live with the discomfort and make that decision for herself, not realizing that, well, some of these things could actually be addressed if you would be willing to share them. And, you know, being as an adult child, I tried to not meddle too much. And being a social worker, she just didn't want any part of that. So, you know, it's the fear of things, not understanding. You guys have talked a lot about education. I think it's also the education of things such as it's okay to grieve. It's okay to be angry. It's okay to not even know how you feel about things. It's okay to not want to talk about it with other people right now or with your family, and maybe to someone individually in counseling, and allowing them that space to kind of process, because everybody processes different and a different timeline, and it's not linear for anyone. And so your family might be in denial and you might be fully in, you know, with it and ready to tackle the disease, and it might be flipped, and you might be like wanting to hide from it, and your family is trying to make some meaning out of the situation and help you as a person to feel better and do the things that's good for you, and you're fighting against it. And so that's why just having the ability to normalize some of these things and talk about them, I think is really important. You know, and of course you can see here the embarrassment, feeling afraid of the response from their doctor, and feeling, you know, like they can't accept it. That whole denial and minimization that I spoke of earlier was huge. And there were some people that I had mentioned before, like lack of support. They also felt like they were burdening their healthcare provider. Their healthcare providers are exhausted. They're working long hours. They're seeing multiple patients. They didn't want to add to your burden in
When it
your
actually
mental health.
makes it easier.
Right, but that was but the mindset came from, well, I just don't want to bother them because they're too busy, or, you know, this, I can live with it. It's just par for the course with this disease, so I'm just going to suck it up and live with it when it wouldn't necessarily have to be the case. You know, so it's a lot of those kind of responses, like I just don't want to be a burden, or I'm going to go in and look better than I actually am, so I don't feel like I've let them down or I've let myself down. And that would be my question. Are you letting them down or are you letting yourself down? Because it can be both, but like if you're the person living with it, and I would imagine, and Lori, you can speak to this or not, like you have to get to the point where how you feel about yourself and whether you have self-compassion for those moments where you feel like you're going to beat yourself up about this.
Yeah. There's a lot of guilt that goes on with a Parkinson's diagnosis. I know it's not my fault, but I still felt like it was bringing it into my family, but it's not. And there's been a big push with journaling these days, and maybe we were ahead of our time, but I got so tired of that I grabbed a first grade notebook that I found in one of my kids' drawers, and I just wrote Mike a note about just stuff that was on my mind, and I handed it, and I put it on his night desk, and then he wrote back. We never talked about what we wrote, but it was a way for us to just like say things that we wanted to say, and maybe we should have one for the whole family that went around. But I think encouraging your family to do that, and you know, like I brought mine to my, oh, I did it again, I'm sorry. I brought mine to my psychologist appointment. He's like, do you mind if I read a couple pages? And I was like, no, sure. But that gave him a sense of what was going on in my home. And I was able to tell Mike things that I really wasn't really ready to talk to him about. But it's a huge thing. It's almost like it is a grief process. And that's important to people understand. Your life that you thought you were going to have is not going to happen. But you're still going to have one. It's just going to be different. You have to make it your own. And you're right. Like, you're not going to be able to have a effective treatment plan if you're not honest. And I will be the first one to tell you, I probably am not honest all the time. I'm getting better, but I was not always honest. Not even close. You know. But live and learn, I suppose.
Well,
Thank you for
that's why we're
sharing.
doing
That's
this
why
now,
we're
right?
here,
Yeah, that's why
and
we're talking
you know,
about it.
like I said, I commend you for even being willing to listen to me and learn about what's going on in my little brain here. So
We have some results in like verbatim phrases and sentences from our survey, so we're going to talk through those. And as we go through, I want to just hear from the panelists. Have you had experience with any of these specific things? So before we get into that, this is a slide showing what our survey respondents said, what they think would help improve the communication with their provider. So they told us what they aren't saying, they told us why, and now we're asking what would have helped. And so here's a graph kind of demonstrating that. So, maybe tools or resources such as writing a message or a journal, like Lori said, perhaps epic messaging, more time, respect for personal agency, maybe, adding another team into the conversation. Maybe that's social work, maybe that's part of the multidisciplinary team. I don't know about you guys, but often physical therapists or another rehab colleague might come to you and say, oh, by the way, did you know X, Y, and Z about your patient? And you're like, no, I had no idea, because they didn't share it with us, but perhaps another team member. And then just the willingness to go deeper from the provider perspective.
I want to say something about that just real quick, because I think we've touched on it a little bit. We've got, healthcare providers asking questions. Sometimes, not all of them, but a lot of them, most of them do. And then we have people that's not disclosing, and because they're uncomfortable. We already talked about the embarrassment and the fear of being judged or, whatever. And so some of the tools, the things that people said that might help them is to have, checklists or questionnaires where they can kind of identify those more taboo subjects. It gives them a bit of distancing. I loved the journal idea because you could write down your real world feelings and experiences. Your family, your husband can respond to that. Your counselor was seeing that. But imagine the benefit of a healthcare provider understanding a little snapshot into what is actually going on. Are you experiencing things? I mean, it's not easy for us to talk about things like erectile dysfunction or other sexual issues. It's uncomfortable. And we had people respond on this survey well, I'm not even going to bring it up to them because they're just going to send me to a urologist, and the urologist is just going to give me more pills, and I don't want any more pills. So there's certainly kind of a feeling of despair that nothing can be done, or it's just going to be more medication instead of maybe there's an opportunity for discussion. Maybe there's a sex therapist or somebody that in a other discipline that can add to that. But if we're not able to give them some kind of a mechanism where they're comfortable disclosing, and quite honestly, not everybody's comfortable asking all of the questions, finding that nice place in the middle where we can kind of give them that chance.
I think to add to that too, just to play devil's advocate, as a provider, the one thing too, we talk about all these difficult conversations, family dynamics, all these symptoms, that all takes time. We're not,
totally.
Blind to the fact that, depending on your setting, there is, time constraints. So maybe the use of these tools to kind of get to a difficult but maybe more pointed conversation because you had some sort of questionnaire with some difficult topics, as opposed to spending the first half of the visit even trying to figure out what those are. Absolutely. Is certainly a way to look at it. Because again, I know time is valuable. You know, there are a lot of patients, certainly, and I know that kind of speaks to that. I know that someone said that about, you know, being a burden to your provider. I think maybe that could be another way to bridge that gap a little bit.
And a lot of people identified tools like that. A lot of people can, like, give me a checklist or like some form to fill out where I can write all these things down and we can cut to the chase, but do it in a more comfortable manner. Yeah.
All right,
I think having a self-evaluation tool from a patient rather than the provider sitting there doing the and you know and face, velvet, church, daisy, church. Yes, that's a hippo and that's an elephant and that's a lion, and I can draw the box, the three-dimensional box. So I'm sorry, I know that's the USRDS and that's what everybody uses, but for 10 years I've been doing that. So, but it would be nice for me to be able to have like something to hand you, more of a sliding scale, like I don't know if you guys know Laurie Mishley, but she does a sliding scale and it's more of an online thing, and not everybody can do an online thing, but it's more of not just a one occasionally, frequently. I mean, those are two, that really doesn't give you a sense of what's going on in my life. And being evaluated in a clinical setting, I know Boss Bloom at the WPC said, a clinical setting is probably the worst place to evaluate someone because they're trying to perform and you're not in your zone, you're not in your area. And you know, some of these, the watches and stuff are great because you can't lie if you fall with a watch on. I mean, it gives you, the data's there. Right. But at the same time, some of those things can provide too much information for like patients like me who got obsessed with it. But you know, there are ways I think that you can, if there are ways to implement a self-evaluation tool for a patient to give you going into an appointment, I think that would be beneficial for both.
It's a great idea.
So you think that just get rid of the UPDRS?
No, not at all.
Well, but don't spend all your time doing UPDRS, but say, you know, here's this sort of checklist of like, are you hallucinating? Are you having?
Just have it be like, this is, I know we're gonna do this, and that's important because that's a baseline for things. But there's also things that are going on with me that might not be covered on that.
Right. And so what would you put on your checklist?
I would put that I'm not sleeping, or I'm sleeping less than 4 hours a night.
Yeah.
Would you want it open-ended or a checklist where you're checking things that are?
I would like a checklist, but not necessarily 1, 2, 3, or 4. It could be like 1 through 5. Put it in somewhere in the middle, and hand that to them when I go in there.
And so, other than sleep, what else would you put on there?
Are your off times there, or are they bothering you? Like, is it disrupting my quality of life, or is it just there? Because obviously, I'm going to treat it differently. I'm going to go, you know. I can't say something bad. I'm going to go at it full force if it's affecting my quality of life, but if it's just a nuisance, I'll tolerate it before I'll take another pill. Right. So it's just kind of like, it depends on the patient, I guess, but I mean, I'm not saying I could save the world and come up with I think it would be kind of cool for us to evaluate ourselves and let you see if we're off base. Maybe you could say like, no.
Because by then you can say, yeah, I did great on this scale that you administered to me, but that doesn't mean anything to me as the patient.
Right.
I think that's
Actually, there was a comment made, and I wrote down some. There's like, have a guide to discuss symptoms in all 3 phases, including motor and non-motor symptoms of living with Parkinson's. The existing test, UPDRS, the non-motor symptom scale, gives a PWP with a meaningless score. So.
Like I look at my neurologist and say, "Don't you put more than a 2?" 2, oh really? and I'm like, "Why did I get a 2? Why didn't I get a 1?" He goes, "Nobody gets 1." I'm like, "Then why do you have a 1?" Like, you know, so if you've done enough like research studies and stuff and been around the block and the PDQRs or whatever PDQs, like they're like the last month. Like, have you had this in the last month? But maybe not the last month, but 2 months ago I really felt like crap and I haven't seen you for a year. So, like, you know, it's just it seems like there should be, with this day and age, a better way for me to communicate with you without taking up more time.
Yeah, and I mean, clearly you're not alone. This is what our survey is showing us, that many people want a way to be able to better communicate what they're not sharing. So let's talk about some of these things. This first one, I am much closer to retiring from this earthly life than my family or doctor realize. The main reasons are mental instability, distress, and future outlook. So this is pretty heavy. And unfortunately, as Anissa mentioned, we received these anonymously, so we don't know how to reach out to this person to get them resources they need. But this isn't just this person. This could be many people feeling this, but they would not disclose it. And this particular person mentioned that this is the reason why they didn't share it. They may respond by putting me in some type of institution or on a hold. And so how do we navigate this? Do you guys have experience with this? What do we do here? Yeah.
I don't. I don't think they're ready to put me anywhere yet, are you?
No. No.
And I'm not really ready to retire from this life just quite yet. But I can understand where you get that way. You know, I've worked with people, and some of them have said, you know, sometimes I get downright offended by all the questions. Like, just stop trying to make my house safer and me safer, and try to make me feel better. And,
Interesting.
You know, and one of my people said, like, we laugh, but we were reading a minute. She said, I look at them and tell them I feel great, but then I get home and I fall down. Like, you know, like that's just how it is. I mean, it's the nature of the beast, I guess, but they're only going to share what they want to share.
Anyone else?
Well, I live in Arizona, so we have to talk about guns. And so we always have to have that conversation, are there guns in the house, and how do we get the guns out of the house? Because we have had several patients commit suicide using guns. And so that's, you know, just like driving, another very uncomfortable conversation that needs to be had very early on in the disease progression before we get to this point and somebody has a gun.
Well, and are you addressing this in your patient visits? Are you asking, you know, are you always asking about mood and how they're feeling? Like, how do we get this out of somebody who might just not come in and say, I'm feeling really down or really, you know, unwell?
Well, the UPDRS actually helps with that, because you're asking questions, you know, how's your memory and thinking? How's your mood? Are you having any, you know, vivid dreaming? And right under vivid dreaming is hallucinations, right? And so it kind of helps bridge and opens the discussion. And I'm from Florida, so another gun state. And I know we have some people from Texas, so, you know, Lone Star State right there. But the other time where we have to really be careful and ask about gun safety is when there are hallucinations.
Right, exactly.
Because this is where you've got 90-year-old grandpa in a shootout, you know, because he thinks that there's someone out there trying to break into his
or
home.
his favorite armchair, and thankfully nobody was in the armchair.
Yeah, exactly. So.
I think a lot of places are also implementing, you know, screening regularly now, domestic violence screening and, you know, suicide screening. I think it's, you know, when I look at this person's response, clearly they know what they're doing, and they intentionally know that if they say something, they're going to take action, and what that might be. If they tell their family, they know that that's going to cause them distress. So they've thought this through. So that's even more concerning to me, because it seems like when they've gotten to that point, that's when it's a little more serious.
And so this next person responded that they live alone, they don't have a care partner, no children, and their siblings are unable to, you know, they don't live nearby, but they are very depressed, apathetic, and fear of the future. And they didn't share that with their provider because they're embarrassed, and they want to look their best at their appointment and keep things together. We see that a lot, unfortunately, right? People coming in, like we said, and putting on their best.
And it's not just symptoms, it's what's going on at home too.
And then this next, I have no one that is qualified to counsel my spouse and me on how to cope with sexual dysfunction and that we face with erectile dysfunction and tremors. And so they don't, you know, share this. A second one on sexual dysfunction. I'm embarrassed to talk about this, even though I'm not sure the neurologist would even be helpful. Can they even improve my mood? And will they even be able to help? So they say they won't share this because the movement disorder physician or provider will just refer them out. They won't even really acknowledge it. And so, you know, they'll get more pills, they'll have invasive procedures. They're worried about if they say something, are they gonna do nothing or are they gonna take too much action? Kind of, it seems, right?
I think there's like, if you could be in a big center where you could leverage social worker and a sex therapist, where you could have more. So I mean, if we don't know that these things are going on, then we can't sort of figure out how to get those resources to the patient. But then you can find a sex therapist and be like, hey, sexual intercourse is more than just penetration, and this is how you can go about it. So if the urologist didn't fix the issue, there's more things that can be done, and you can still enjoy a good relationship with your partner. But I think, that's where we sort of, and I think so, we can leverage things like PMD Alliance and ATMRD and be like, okay, my center doesn't have a social worker or a sex therapist, but hey, call PMD Alliance and they know a social worker or a therapist that can Zoom with you, or, and so we could leverage that.
And again, for topics like this that can often be embarrassing or uncomfortable, the patient doesn't often, or maybe not often, bring this up on their own. Are we asking questions like this? Are we asking the uncomfortable questions to make sure we're addressing everything? And should we be? Do you guys do that in every visit, healthcare providers? It's hard, right? It's hard to know what to focus in on.
I think on an education piece, though, you can also, another way to, again, it's hard to know if you don't get to the root of that, but maybe even being more open about the fact that just in general, we talked about education, but also saying there are more resources now.
Right.
Maybe you don't actually get this out of the patient, but if you get ahead of it by saying, you might have issues with X, Y, and Z, but there actually are more treatments and more avenues and different sort of education and support than what there was. I think that might be another way to kind of get people to come out of, about some of these certain symptoms kind of proactively as opposed to on the back end.
Yeah,
Oh yeah, I
great
think
idea.
so. And sort of like, like the PMD Alliance, the YouTube channels, and, there's podcasts on sexual health and Parkinson's disease, so you can point them to that and they can listen to that. So if you don't have, the 10 or 15 minutes in the clinic to discuss all of these things, you're like, hey, PD Avengers did a podcast on sex and PD, why don't you take a listen to it?
Yeah, many avenues for different people that like different ways to learn or get their education or
Right.
information.
I'm still on Zoom putting my hand up. And another way, I mean, again, you have that different demographic where, not everybody's going to go and watch podcasts or go onto the computer, but the National Parkinson's Foundation has a 1-800 number. They will send a book, a real book, to your house. And the Davis Finney Foundation, Every Victory Counts, is one of the best informational books I've seen. I don't know if I'm supposed to do that or not, but it talks about medicines. It talks about, it's an all-inclusive one, and they will send you a book. And there are resources out there that people can get credible answers and educate themselves without having to do a webinar and having to log on, and because that's not everybody's thing. I mean, it's great that COVID has given us those resources, but you still have that group that you need to reach that doesn't do that.
And you're allowed to say that. And I will just say that APDA also has the Parkinsex. So there are resources out there for people.
But then there's, Anissa, like your mom that you were mentioning. There's
Yeah.
people out there that want to be the ostrich with their head in the
totally.
sand. And is that okay? Yeah, that's okay, for them, right? But we're just want to be able to come up with ways to kind of bridge that, so that if it is a topic that, maybe they're not mentioning it to us because they really think there's not any resources or anything that we can offer to them, we're bridging that gap and then hopefully starting that discussion so that we can get that person the resources or help that they need. And it doesn't always have to be a pill or a procedure, but just people assume that that's what our go-to is going to be in medicine, and that's not always the case.
And support groups. There's lots of them, and we're out here, and PMD Alliance is a great resource that got me into it, and we talk about a lot in our support group, and if you can get somebody to get into one, either virtually or in person, it will change the way they look at things. I can almost guarantee it. I can't say it with 100% certainty, but I'll go with 99.
It often helps them to then normalize these things that we're talking about, that often also then encourages them to talk about it with their healthcare provider. So they realize, well, I'm not the only one that's dealing with this, so I guess I'm not an anomaly. I can go and talk about it. This isn't uncommon. Or they may have developed with a rapport with others there, and they feel better about their situation. And so sort of dealing with that coping and all of that, they actually then might feel better. Because a lot of times it's not so much that they're even embarrassed or afraid, but there may be just a lack of motivation to deal with things. Like it's just, there's too much. There's just too many things to deal with. I have medications to deal with, and I've got all these appointments to deal with, and it's just one more thing. Like I can just live with it. Like it may not be the best thing, but you know, I've had several people say, well, this is just the lot in life I have, and it's just easier to live with it and accept it than it is to try to fight it. So those are, you know, and I guess part of that is deciding, you know, where are they really, and allowing them to self-determine whether that's important to them or not.
And I think going back to the support group situation and, you know, finding other resources, I know you've told me before where, you know, someone in a support group has, you know, asked you a question about like a medication or something, and you had the ability to be like, you need to discuss that with your physician, like, you know, and that's somebody else that's not a care partner, that's not a family member saying, you got to talk to your doctor. It's somebody else that they level with that says, look, we're here as a support group, but this is something you do need to discuss with your doctor to get the right help you need. That, you know,
Right,
that
encouraging them.
Exactly, encouraging that, you know, honest communication. So maybe if you are more upfront in the beginning, hey, there are other resources. If you're not comfortable talking to me about it yet, you know, there are support groups, there are other things, so that maybe it kind of comes back to you in a different direction.
And yet some of the support groups like ours has, like we have educational people come and talk all the time. And just the simple things people like will learn, like, you know, when you take your carbidopa, don't eat a cheeseburger. Like, don't take it with dinner with a cheeseburger. You'd be amazed at how many people really don't know that. And that should be like carbidopa 101. But like, there may be simple questions that they're dying to ask you, but they don't feel like, oh, that's a stupid question, that they can ask at a support group and they can get that kind of information. So it might make their appointments actually a little more productive.
Great. So we'll go through a few more. I haven't shared about incontinence with my movement disorder doctor, but my primary doctor knows about it, and I do go to a urologist. And they haven't shared it with their movement disorder physician. Sorry, I'm going to go into another what. It's the same topic. One of the most embarrassing things to deal with is incontinence. Sometimes I don't go out because of it. Urinary symptoms and how frequently I fall. So you can see a lot of people it's the autonomic dysfunction, it's the urinary dysfunction. And this is one of the most common reasons why, if I'm not honest about how many times I fall, because it makes me feel like a failure, or I don't talk about bladder issues because it's embarrassing. Again, you know, a common theme we're seeing. I don't like to talk about my cognition issues. We were talking about this earlier. It's a really tough topic to bring up. Or maybe perhaps the perception's off. The patient feels like, you know, the person living with us feels like they are doing better than they think that they are. But I worry that it may, you know, exclude me from being a candidate for DBS. Cognitive issues, sexual relations, changing dynamics of a relationship, changing roles in relationship, that's challenging, but they don't want to discuss that. Mostly because, okay, for this person, the person with Parkinson's is in denial, is embarrassed, and has difficulty handling Parkinson's issues. So this was a care partner sharing some of the things that they're not disclosing in the patient visit as well. More cognition, feel like I have failed and it's embarrassing. I would open up the floodgates. Some of these other things, they're feeling like their provider is not going to do much. The actions would penalize them, or perhaps they're too embarrassed and ashamed and they don't recognize the ICD behavior. So that's an interesting one. Another one from a care partner that we see, and this is often coming to us like on an epic note, right, before we see our patients.
And that's a significant stressor in a marriage, especially, you know, when it's around the sexuality thing, because it can, you know, often become a burden to the partner, to the spouse. There's been there was one that disclosed that it was this one, that they had gone outside of the marriage and they ended up in a divorce. So it can cause real issues in a family. And one of them, I don't know if it was this particular one, yes, it was. He knew that he was related to impulse control disorders. He disclosed that he was overeating and spending, but he didn't disclose that he was hypersexual and had an affair, and it was in a divorce because he was embarrassed.
Couple more here that we have. Oops, sorry. So this one was an interesting one. Somebody disclosed that their husband or partner is not any at all involved in their care, and they're pretty much on their own. But they don't share it. The husband doesn't go to the appointments, but he would just get angry, and call, and nothing would change. If he got a call from the provider saying, why aren't, what can we do to help support you? That patient might go home, and it might be worse for that person at home. Interesting one. So that's where a social work again, or somebody to lean on, is a support group. So what would help? These are directly from our patient survey. Some of the things that they feel would most likely help improve with communication. And I want to just talk to this group. What are some techniques that you have used to help get patient concerns out? Do you ask open-ended questions, and how do you provide that safe patient space for them? What does that look like? And perhaps as a care partner or as a person living with Parkinson's, Lori and Adam, you could also talk to, that safe, non-judgmental environment.
I think that's getting back to giving that patient a chance to be alone with and say what's really on their mind, because you're more apt to be open. And I also think that the you need to understand, especially the young onsite community, that we're smart and we want to help. We want to help each other. And we want to help ourselves and help you help us. And that was a really fast mouthful. I'm sorry, but we have the ability to do it if you give us the tools to help you. And I think that's the trust thing will go both ways. And I think that's kind of important.
I think from comparing your less than ideal situation in the beginning to where things are now, I think a big difference was just really just about communication and personability, as well as again, I mentioned it before about time, having an actual conversation versus just, the way you were diagnosed was, it looks like, I think you might have Parkinson's, and that was the end of the visit. And that was led to some bad things for a while, but, just being able to have, the ability to build rapport, have that open conversation, and feel comfortable to do so.
I think just, asking open-ended questions. Are there things that you want to do that you can't do that you still want to do? How can we help you get there? Kind of thing.
That is one question I ask myself. Is there something in my life that I want to do that I normally could do and no longer can? And if I get the answer to that question is yes, then I need to look at my care plan and how much medication and what I'm taking.
Oftentimes I'll use the UPDRS in its entirety because it does help, open up questions about the hallucinations or hypersexuality or the sleep issues too. They're all part of that UPDRS. But then the other thing that I'll do at the end of the visit is I'll ask the person, was there anything that you wanted to talk about that we have not already discussed so far this visit? And, sometimes every once in a while there is something that someone will bring up that that we hadn't touched upon and may have been uncomfortable, but because I allowed them to be able to add that to the visit, we were able to discuss and address those issues and try to find something that was a resolution for them. And it's not always about medication, because I do hear that from a lot of my patients. They don't want to increase med or, add a new medication. And sometimes they're not aware that there's other alternatives, whether it's through physical therapy, occupational therapy, physical therapy, there's pelvic health, rehab, or, meeting with a social worker to kind of try to get additional resources that may be available for them for extra help in the home. So that's helpful with patients and during appointments.
Is it common practice now for, many of you healthcare providers to ask the patient if they want to be, to visit individually without their care partner? Do you do that every visit? Should we be doing that?
Yeah. I mean, I like what Lori said. I have not done that on a routine basis. I have had where the patient had to go to the bathroom and then the care partner was like, while she's gone or while he's gone, let me slip this in. But no, I haven't thought about that, and thank you for that information because I will start using that.
You're welcome.
Yeah.
And we know that the use of telemedicine, sometimes even just being behind a computer screen or the EMR system that can help with disclosure, the patient portals, anonymous surveys, or even the rating scales can help. Do you guys have, one piece of advice, a pearl, something that you would like to share or, that you're taking away from this topic and conversation? Adam.
So I would say the one big thing that I've seen from both my family dynamic as well as myself as a provider that I was able to take away from is that in every situation, especially in this particular disease, that there is always that family dynamic that you need to be aware of as a provider that, again, may not be very easy to get to, may not take one visit, may take some time, but to understand that it's not more than likely not just affecting the patient, but it's affecting more than just that, and that the social history, which can be a little bit tricky, is probably going to play a role in how well the patient is doing.
Yeah, great. But Lori, do you have
Me? Okay. It's clear that there's more of us than there are of you, and we are outpacing you, and I understand that I am one of probably hundreds of patients that you have, but it's important for me for you to understand that you're my only doctor. Mm-hmm. And I need you to know that you're my only doctor, despite I might be one of your hundreds of patients. And you having that connection with me is important.
So I think with that, then, maybe, having more follow-up visits, not maybe every 3 months is too far apart, that maybe you should see them closer together, even though you're not changing any medicines, they're pretty stable. But it would be, a 6-week follow-up to allow them to bring up other things that weren't brought up. Yeah, the motor symptoms are well controlled with medicine, but there's all this other fine dynamics or other things going on, and so that just gives them a little bit more time where we're not really talking about UPDRS, we're talking about whatever else is going on in their life.
Yeah, it sounds ideal. It's hard to find that, though, right?
Right.
Right.
Every 3 months, whoo.
Yeah.
Well, I agree with what you say. Most of my patients, once I've optimized them, I see them once every 6 months, but every once in a while I'll ask the person, normally I see you every 6 months. Do you, especially if there was a lot going on at that visit, I'll say, are you okay with being seen sooner in 3 months? And the reason I say, are you okay with that is I also have patients who drive great distances. So it's not like they're coming to me within the same city. They're driving quite a great distance. And so it's a matter of whether or not coming back sooner is going to be a hardship for them. And if I do know it's starting to be a hardship, the other thing I offer, which you've mentioned a couple of times, is a telemedicine. And COVID was not fun, but one of the best things I think about COVID is that it did open up telemedicine because there were so many roadblocks for telemedicine before COVID. So yay to COVID for that.
Keep talking to your congressman
Yeah.
so that we can have it
Continue
beyond
that, yeah.
December of 2024.
Yeah.
Right.
I would just say, obviously, you guys have touched on most of it, just that whole time thing and building up that rapport and relationship. But you don't have to be all things to your patients. There are other resources out there, even if you don't have a social worker or support groups. One of the things that when we did the webinar of this at PMD Alliance, and actually it was Dr. Torjagi that joined in, and we had the conversation about this. And when we went through sort of each thing that people weren't discussing, and he kind of shared from his perspective, and we invited the audience to share from their perspective. We did a poll at the beginning, and same thing, most of them were not telling something. So I think that's one takeaway, is that there's probably things out there the majority of your patients aren't telling you. But then after this conversation, because they had an opportunity to hear that perspective and realize this is actually impacting them and why it's impacting them, because he sort of unpacked, like, if you're having this, we might be able to help you and it can improve your quality of life. Here's why. They had a better understanding. So there's that educational piece too, that when we polled them at the end, they actually said, yes, I actually see the importance of now disclosing. It will change my behavior. So there is that opportunity too. So maybe we approach it from that perspective, so you don't have to necessarily have all the answers or even like assess all of those answers, but maybe we just preemptively say, listen, there may be things that you don't necessarily know that you should disclose, you're uncomfortable. Over time, we'd like to sift through those and give you opportunity. What would make you most comfortable? Would you like to write it down? Would you like to talk to somebody else and find out what works for them? Everybody's different. So there might be that opportunity, and there are resources out there that give them that information. PMD Alliance has tons of videos in their library that kind of touch on, we love diving into these deeper topics. We think it's important, and it empowers people to realize that they're not alone in some of these experiences, and that might be the mechanism for them to feel comfortable disclosing.
And I have one more thing to add about APPs, because that's what a lot of you guys are sitting out here, right? Make sure that everybody, the patients, know that you are qualified to answer their questions, because somebody said it earlier, you have the time to do it, and and I'm biased, of course, but it doesn't, like my mom and dad, it's got to be the doctor. No, it doesn't.
We're working on it.
And I think, I mean,
We're working on it.
get your seat at the table. I mean, let your patients know that you're qualified to answer them, because when I'm in a crisis mode, I just want somebody to talk to me.
It's extremely important, and thank you for saying that, because it is a whole care team, and there's different people that you may relate to on your care team and you want to speak up to, and oftentimes it is the APPs who have time, or the social worker, or the therapist, or the rehab. I love the idea of taking that first visit and saying, how do you want to communicate with me? How do you want to tell me about hard things throughout your journey and how things go? That might open up the door to really bridging a trusting relationship right away. It's clear that there's a lot of work to do. 82% of patients that we surveyed are not disclosing something. So I hope that today you were able to take away some pearls and some tips on maybe how to bridge that gap and to grow conversations a little bit deeper. Thank you to the panelists. This was great to have all of your perspectives. Thank you so much for being here, and thank you guys for attending today, and we open it up to experience and questions. Thank you.